First off, Anne, thank you for inviting me today, and thank you all for joining us. My name is Bryan Adler. I'm a board-certified elder law attorney with Rothkopf Law Group in the Philadelphia area. My practice primarily focuses on elder care advocacy, more or less helping families and their loved ones find the best care possible, pay for without going broke. We have a unique approach to our practice, which is why I'm so involved in the tech area. In addition to our legal team, we have a half a dozen social workers and elder care advocates that work with our families to not only put a care plan in place, but continue advocating for that care and looking for ways to get the most amount of care for the least amount of dollars. And that's where our age tech practice group comes in as well, how we can manipulate and use technology to provide the best care possible, figure out how to pay for it, again, without going broke. So we're going to talk about a lot today. The purpose of our discussion, the goals of our discussion we'll go through in a moment. But what I have on the screen here today is the all-new Atlas robot from Boston Dynamics. The original Atlas came out, I think it was 2 or 3 years ago, and was a pretty revolutionary robot in its capability. It was able to manipulate objects and manipulate those objects in such a way as it knew what level of force to put on, for example, to grab a hammer versus an egg. It had a lot of mobility and dynamism. The new Atlas is even more dynamic. I'd like to take the opportunity to show you what this robot is capable of in a brief 30-second snippet, because we're going to talk more today about where technology is taking us, particularly in the elder care and healthcare sphere. So we'll start with this video, then we'll switch over to the discussion. There's no audio, it's just the robot itself. Okay, so that's very brief, very short. I acknowledge that was quick. I encourage you to look at alternative or additional videos of this new Atlas. It really is impressive what Boston Dynamics has managed to create here. And again, as our discussion progresses, we're going to hit a little bit more on where that technology can take us, particularly from a healthcare perspective. So the learning objectives for today, the outline of our discussion is, why should we care about technology? Now, knowing that I'm with AITC here, I think you've already caught up to that. You already care about tech. So we'll kind of skip over that in some regard. But we are still going to talk about it, particularly why we care about it in the elder care and healthcare arena. Talk about where the current state of tech is in elder care, meaning the old, the now, the future, and what the concerns are related to adopting even current technology, let alone future tech, AI, robotic caregiving, and the like. So starting, why do we care about elder tech? Well, number one, the math just doesn't work. The number of individuals that are aging into the need for care is staggering. Right now, there are over 1 billion people on the planet over the age of 60. Many of them are still healthy and active with discretionary income, but that age group is growing faster and faster and faster. And it's an unprecedented demographic shift that we've never seen before. So not only are we dealing with a reverse population curve, meaning we have far more older individuals and far fewer younger individuals, meaning the replacement number isn't there. That's only part of the math equation. We don't have enough people to provide the care, not only because our birth rates are lower, but because we don't have people that necessarily want to work in that industry. And we don't have enough money. It doesn't matter how much money you have if there aren't enough people to provide the care. It doesn't matter how many caregivers you have if you don't have the money to pay for it. So we're dealing with a math equation that simply doesn't work. And if you look at historically, what has lifted us out of these financial or human resource issues is technology. If you look back all the way to the railroads, horse and buggy was a difficult way to transport anything. Railroads made that easier. Cars were difficult to transport things. Trucks made that easier. Boats were difficult to get things across the ocean. Planes made that easier. And tech is what is going to lift us out of this It's not the complete solution. It's not the only solution. It's a tool in the toolkit. We need better healthcare. We need better preventative care. We need more individual responsibility on the healthcare and financial side, but tech is going to help us get through this pretty dramatically. So here's some facts about age tech and why we should care about the use of it when it comes to the aging population. More than 75% of our seniors prefer to age in place. Now, the definition of that isn't quite what a lot of people think. Aging in place doesn't necessarily mean staying in the house that you're living in. Aging in place generally means independence and living where you believe home to be. The majority prefer a mix of medical professionals and healthcare tech to alleviate some of the burdensome responsibility of going to your physician, scheduling things. They would prefer to see if tech can intervene there. There's a $7.6 trillion expenditure on goods and services in 2018 by Americans over 50. So there's a ton of money. And in the next 30 years, that's going to almost more than triple, almost quadruple. And they're willing to spend money on tech-supported aging because the baby boomers, being the first generation that came up with really fast advancements in tech, they recognize that the cost comes down. They recognize that it can enhance quality of life. And our professionals understand it can reduce errors. It can reduce hospitalizations and overwhelmingly reduces costs. Looking at this from a geriatric perspective and from a baby boomer perspective, we're seeing a group of individuals that are wildly accustomed to rapid technological increases. We're looking at, if you look at my parents, my father is turning 77, I think. My mom is 75. They came up with cars that didn't have airbags or brakes, or analog brakes, or CD players, or GPS. Now cars have all of that by default. They came up with television, then cable, then VCRs, then DVDs, then TiVo, and now the DVR. It's a rapid increase in tech, so we're dealing with a population that's increasingly more comfortable with it as well. So that's the consumer side. On the professional side, we're recognizing how easily, once implemented, it can start to bring down costs and open accessibility. Now, this Lincoln County, Maine assisted living facility study, it's dated. It's not quite as new as it should be, but I use it because I think it's a nice little bellwether. It's a canary in the coal mine, and it's very simple to understand. This assisted living facility equipped its caregivers with a tablet to track the care provided, meaning the hands-on touches, provide reminders to the care staff, and it would analyze patient health status. So it tracked vitals, medication consumption, heart rate, temperature, blood pressure, symptoms, things like that. And it was real-time input. So the system was analyzing what the needs were of these residents, of these patients, so the intervention could come more quickly. And the results were not surprising. Fewer transition to nursing homes out of clinical need, fewer transition to hospitalizations, and they estimate in this one facility a $400,000 in care cost savings. And this is not revolutionary. This is a tablet that tracks information and was not AI-based. It wasn't analysis-based. So you can see with this transition to AI, as it starts to grab and digest and vacuum up more and more information, it can start to analyze, assess, and diagnose far earlier to, again, further reduce need for nursing home, hospitalization, and further savings. By the way, I didn't mention this. Feel free to put questions in the chat. I think I'll answer some of them as we go along, but if not, by all means, feel free to drop them in, and I'll read them as they pop up if they're appropriate for the conversation at that time. If not, I'll get to them a little bit later. So the current state of elder care and healthcare, frankly, on the financial side is kind of discouraging. Our seniors are overwhelmingly unable to pay for long-term healthcare, meaning whether it be a nursing home, whether it be assisted living or home care, because the reality is it's extraordinarily expensive. Now, I'll use my experience here as an elder care advocate in Philadelphia. It's a major metro area. Cost of nursing home care, give or take, $500 a day. That's right around $15,000 a month. Assisted living, it used to be around half of that, but we're really seeing those costs creep up, I'm telling families 9 to 10,000 a month for assisted living or memory care, and home health care, meaning a home health aide, all for the hands-on side of care, the personal care. It's a little bit more difficult to pinpoint because it's hourly based as opposed to a daily or monthly rate. And what I mean by that is you pay by the hour. Someone hires you and you pay for it. So you're looking at about $35 an hour, 24 hours a day is $20,000 to $30,000 a month. Now, Bill just wrote a question. I'm going to read this. And he wrote, not to be overly cynical, but all this represents increased healthcare costs. A growing number of U.S. elders are retiring abroad for this reason. What is the answer? It's a good question. There are increased healthcare costs, and it's largely being borne by government health insurance. However, government insurance pays for healthcare, meaning Medicare, Medicare Advantage, Medicaid pays for healthcare. Medicare does not pay for long-term care. It is all private pay. And Bill, there is a small contingent of Americans that are leaving the United States to retire, Mexico, Western Europe, some Canada, but the majority of our seniors today simply don't have the financial wherewithal to do so. So really the answer is all these levers in front of us. And we're going to get to this to a certain extent, but there's no one solution here. Just yesterday, the Biden administration announced minimum federal staffing standards for nursing homes. First time ever that there's been a minimum number of hours of hands-on care that a nursing home must provide to its residents. Now, states like Pennsylvania implemented that a few years ago, but still, it's these minimum requirements. Okay, well, minimum requirements of hours per care means you have to have a certain level of staffing, which means you have to have a certain level of revenue to pay those staff, which means you have to have a certain number of residents and patients. So just having a staffing mandate doesn't mean you're going to have the staff. Having the staff doesn't mean you're going to have the revenue. Having the revenue doesn't mean you're going to have the staff that you need. So it's all about pulling these levers. And we're going to talk about this actually right next. These limited resources that our seniors have, it's financial. They have limited financial resources because it's very expensive to pay for care. Again, anywhere from $10,000 to $35,000 a month. And our baby boomers have not that kind of scratch. The baby boomers are far more polarized than their parents and grandparents. You have the ultra wealthy, and you have far less wealthy, and then you have those in the middle. And the ones in the middle have a house, maybe $500,000 if they're lucky. And when you're talking about $200,000 a year plus just in care expenses, it eats up their resources very quickly. Now, that's the care recipient side. On the provider side, these caregivers are paid $15, $16, $17, $18 an hour at best. Maybe a 401k, maybe health insurance. But the reality is the pay is so low and comparable to or less than Target, Chick-fil-A, McDonald's, Starbucks. So when you're faced with a comparison of going to work at Starbucks and getting educational reimbursement, a 401k, when you're faced with working in fast food, where at least your constituency might be kind of grateful for what you're providing to them, and your customers might be grateful, versus caring for someone who is only getting worse or frequently getting worse, may have a cognitive impairment, cannot express gratitude, or is even the opposite of it. They're angry or aggressive. It's a difficult sell to say, come do this hard, backbreaking, physically and emotionally intensive job for the same or less than you could get elsewhere. It's far less exhausting. And we have public benefits, Medicaid, Medicare, veterans, health insurance. The reimbursements are flat. They're not paying more with the cost of care as cost of care increases. Point in fact, the cost of care in Pennsylvania, and I speak from experience, over the last 5 years has gone up significantly year over year, particularly nursing home and assisted living. The Commonwealth of Pennsylvania, Department of Human Services, has published every year the statewide average cost of nursing home care, and it has gone down. Starting in 2021, it's gone down every year from like 15,000 to 12.5 to 12.25 to under 12,000 a month. And it could not be less accurate. I have no idea how they come up with these figures, but it's an indication of the government seeing data that might not be the reality, or is too generalized. It's too averaged, over all of these geographic areas and doesn't create reality based on geographic disparity. Public benefits don't cover a lot. There's not a lot available to pay for care. Point in fact, in Pennsylvania, Medicaid is really only available in a nursing home, but it's rigid and difficult to access. And everything's getting more expensive. Everything. And what that means is, I talked about this earlier, the seniors having, everyone, Americans, not just seniors, increased personal financial responsibility. Yeah, that means save more, but only if you're able to save more. Everything's more expensive now, and that's cutting into everybody's ability to save, pay for things like long-term care insurance, or just save their own resources. So these are all the sort of buttons we have to push when it comes to the financial side. But then we look at the social side, which is not really that much better. Lack of caregivers, we've talked about this, the math not working. There are immigration issues. Overwhelmingly, caregivers are immigrants, and we've got all kinds of problems with immigration in the United States. And it's not a political, I'm not jumping on a political bandwagon here, regardless of which side of the aisle you're on. A lot of these care providers, these caregivers are immigrants. And if we tighten that noose and don't allow immigration for this reason, you're going to narrow the worker pool. And low pay, we talked about that as well. And that's on the hands-on care side, the individuals providing care. But let's take a higher level view at the actual care models. Well, we have an aging infrastructure. The nursing homes there are some that are 10, 15 years old. There are some that are 30, 40 years old. The infrastructure is aging. It can't be replaced easily because you can't displace these residents. The communities are often gigantic, plopped in the middle of a major highway, and with cars whizzing past, doesn't feel like a community. And the United States has overwhelmingly embraced the warehousing approach to long-term care. If you drive past a nursing home that's 40, 50 years old, or even 10 or 20 years old, it doesn't look that much different than a storage, a WE store, where it's just garage after garage after garage. This is just room after room, with caregivers so overworked, so overwhelmed with their duties. They go in and they're checking the box: dressed, bathed, brushed, dressed, out to breakfast, move on. There's no real human connection anymore because of the stripped down staffing, because of the great need for actual care, and all the litigiousness and liability. There's all these things that go into it because we have a lack of innovative care models. And then we have the clinical side. So social is the actual care provision. On the clinical side, there's a focus on medical versus social, meaning let's address the medical issue and not the surrounding issues that are creating it. We look at adult onset diabetes. Let's create healthy eating programs, exercise programs, and encouragement there, as opposed to treating it with a drug. But we have a medical versus social model. And we have a life versus death model. For many physicians, death is failure. When it doesn't have to be death, but a dignified death can be success. If you look at someone who has reached the end of their life, they recognize this themselves, and they present with a tumor or some sort of condition. Do we have to look at surgical options just to extend their life by 3 to 6 to 9 months? Maybe, maybe not. The person should make that decision with a broader view of things, not just we need to save life in favor of or instead of death. So there's the provider coordination. There's hospice and there's palliative care. I acknowledge that, but we have the provider coordination isn't there, and we have too narrow of a clinical focus with treatment versus prevention. I mentioned to Anne when we were first sitting down, we were kind of getting ready to start the presentation, and I mentioned the United States has sort of demonstrated that we tend to be a little late to the party, but we often will leapfrog our competition. Look at the moon race. We weren't the first to space. We were the first to the moon. So I think if we can, it's difficult for me not to be cynical because of what I've seen and what I experience every day. But if we look at this as, okay, we're starting to recognize the problems. We're starting to recognize the provision problems. The government's getting on board. Maybe instead of deriding the fact that we're a little late to the party, let's embrace the fact that we're showing up at all and look at this as a moonshot. We need a complete reimagination of the provision of elder care and long-term care. For example, the communities that are provided, the healthcare that's provided, the social supports that are provided. We need to look at medical aid in dying, letting people choose to end their life if they wish to do so, and there are a handful of states that allow that. So we've looked at the financial, the social, and the clinical issues facing our seniors and our healthcare industry today. There's not enough money. There's not enough caregivers. There's not enough focus on the big picture. It's too narrow. We're wearing these blinders that are looking at it as one problem to fix, then moving on to the next one. So that gives you the foundation for where we are from a tech perspective and where we are from a care perspective. But let's look at some of the tech that we have. Nothing revolutionary here, the old. The personal safety monitoring, that's the I've fallen, I can't get up. That's been around since like the 80s. But there are some changes coming. The Apple Watch being one of them has fall detection. And that's a device that attaches to something that people are very used to, and we'll talk more about that. Medication management, that's the device that drops the medicine into a pill or into a cup, take the medicine, it sends out an alert if the patient doesn't request the pill, if the patient requests the pill more than once or fails to take it. So you can monitor it that way. We have companionship, and that's more like FaceTime, Zoom, things like that. And of course, telehealth, which was around far earlier than the pandemic, but really got legs and traction at that time. That's really the old tech. That's the stuff that we looked at as revolutionary in the 90s and the early 2000s. What's kind of happening now? There are a number of things. I have some examples here. One is LEQ. So let's go forward, and this is LEQ down bottom left. LEQ is a personal assistant. It's interactive, conversational. How you doing today? How's the weather? It is more AI based than your traditional like Alexa. You can have a real conversation here. Up on the top left is Pero. That's a caregiving seal. It's for individuals with Alzheimer's or dementia, and it's designed to help soothe them. I've played with Pero before, and a friend of mine, Liz Broadbent in Auckland, New Zealand, was on the development team. Pero's very soft. He or she or it, however you want to personify, coos, snuggles. It's very soothing. I enjoy it myself. And bottom right is the Ageless Innovations. It's a robotic dog. I've got my cat sitting here behind me. I pet her when I'm having a stressful day. Ageless Innovations isn't quite as new anymore. Pero's a little more dynamic, but it's a way to provide pets, provide soothing and calming interactions without any additional work of pet caring. Now, top right, we have the TrueLoo. This is a toilet seat that analyzes your 1 and your 2. What comes out, it analyzes it to determine if there are any markers for infection or a problem that might not be symptomatic yet. One of the biggest reasons seniors are hospitalized because of a change in cognition, which is usually caused by urinary tract infection. By the time it's symptomatic, it's really accelerated. The TrueLoo can identify those markers earlier, ideally getting intervention in sooner and avoiding or minimize the need for hospitalization. There are virtual reality glasses that are being used to rehab neurological connections after brain injury, stroke, spinal cord issues, things like that. So we're looking at all of these different technologies that can be used right now. Virtual reality, for example, was not developed for neurological issues. There's a toy, and now it's being engaged much more heavily on the medical side as well. I remember reading an article. This actually catalyzed my interest like a decade ago in age tech. I was reading an article, I think it was in Wired magazine, about the Consumer Electronics Show in Vegas, and an attendee, a younger attendee in his 20s, was lamenting that there was no tech for them. It was all healthcare and age tech. And the reporter went on to show that the reason for that is because the millennials had no money. All the money's with the elderly, with the aging, with the baby boomers, and that's what they're pouring all their dollars into, and that's what got me really interested in age tech. So the future, this is where we're going in the coming, I would say, 5 to 10 to 15 years. Now, let's go through here kind of one at a time. Up here in the top, this is Sophia. She's a caregiving robot, and she's horrifying. I acknowledge that the human face, there's a body of research that suggests that robots shouldn't try to have a humanoid face. It's never going to look like a human face. It can be disconcerting, be a turnoff. But regardless, this is Sophia. She's an interactive robot. She can take your vitals while engaging with you socially. I encourage you to look her up, watch the video. She's a product of Hanson Robotics out of, I believe, Singapore. As scary or horrifying as she may look, you have to think about where we've come. So it's only going to get better, and the capabilities of this robot really are pretty astonishing. So I encourage you to take a look at that particular robot. Now, the others, the right over here with the gentleman and the bottom, this is Tiago. This is, I forget the other name, Stevie. Tiago and Stevie are social engagement. It encourages singing, karaoke, some exercise. And there is even one that delivers meals that you can use to deliver trays of meals. Now over here on the left, this is Bear. Bear was originally designed for the military. Battlefield extraction assist robot. Military is particularly good, and the government's particularly good at coming up with an acronym and then backing into it. This is designed to pick up wounded soldiers without sending another soldier into risk. So you can see there's leg mobility, hydraulic power up top. This is being repurposed for elder care and senior care to avoid the common injuries from poor body mechanics that a caregiver has. No human can maintain perfect body mechanics, bending and lifting a patient or a resident all day long. A robot can. So if we can implement this and repurpose this, particularly like Atlas, it can be pretty valuable. Now, before we move on to tech adoption trends, I'm going to touch on some of these questions because there are several coming in. So Grayson Robinson writes, do you agree there needs to be a fundamental shift around prevention, i.e. preventative interventionary measures and technologies to reduce risk to help stem the fallout, care gap, incurred costs, and staffing required by so many of these injuries? Doesn't getting ahead of the curve matter? With 2 question marks. Grayson, I couldn't agree more. Our entire medical and care model is reactionary. It is, how do we address the issue once it arises? Tech is starting to address these. The medical community is starting to address these, and individuals starting to address it. So when you look at prevention, there's multiple perspectives there. One is the simple stuff. Like if you have mobility issues, get a chairlift. If you have, if you're unstable balance issues, get grab bars. Those are the simple interventions. You have dietary and exercise when you're younger. When it comes to the tech side of it, there's a belt that you can wear that has a built-in airbag. So if you have mobility or gait issues, if you slip and fall, the airbag pops real fast and it catches you so you don't break your hip or hit your head. There is prevention there. There is a nanofiber technology company that creates underwear. Well, they're working on this. It's underwear that there's 2 different types. One is to restore mobility and functional mobility. So if you have trouble with balance or gait, it's like an exoskeleton. They continue to shrink. And I think we have some of these in our discussion today. I took them out. There's an exoskeleton that you can wear to restore that functionality, that walking capability. It's getting smaller and smaller and smaller to the point where now it's not quite as slim, but you could probably wear it in a pair of baggy pants. Skin is trying to get it narrower to this microfiber, this nanotech microfiber that will accomplish the same thing, restore that mobility in that gait. Similar concept is a wearable that assesses the quality of your skin, your temperature, your heart rate, your blood pressure to similarly get ahead of problems. Now, looking back at this tech, Grayson, to answer your question, this is preventative. It's a little late to the party, meaning if someone has a degenerative illness, could it have been prevented with exercise, diet, early intervention? Maybe. But by having these wearables, we might be able to prevent or delay the fall, the lack of mobility, and everything that comes with that lack of mobility: decreased bone density, decreased muscle mass, psychological issues, depression, anxiety, that all comes with this need for care, often catalyzed by that 1 or 2 issues they're facing. So yes, getting ahead of the curve, Absolutely critical. There's no doubt about it. Jose Ramos, we need to change our culture to multi-generational families living in a common home. Our way of life is scatter families away from each other. Jose, that is perfectly said. I have I've done research into this, and I present a lecture on race, religion, and sexuality in long-term healthcare, and it discusses the disparities from a racial perspective, a religious perspective, and a sexual perspective, meaning gender identity and actually sexual intercourse. So the United States pioneered long-term care, this institutional living. Overwhelmingly, Hispanic and Asian populations prefer multi-generational housing. The research supports that, meaning the parents take care of the kids and then it flips. And you have grandparents with parents and kids and grandkids all living in one home. Jose, it can't be overstated how valuable that is. The unfortunate reality is that you have these other factors and other influences. For example, the baby boomers are the first generation to experience a diaspora. They left their parents and their kids are leaving them, meaning the kids of baby boomers are more likely to diasporate all over the world. So you don't have necessarily that built-in capability. Furthermore, you have financial realities. When you have the research on this is pretty stark. The amount of free caregiving that's provided by families dwarfs what Medicare pays in a year. The other side of that is when you have a multi-generational household, it can detract from the adult child's ability to work or support their own family because of the financial realities of today. And when you look at that financial hit, it affects that adult child's ability to be financially secure. Again, Jose, good question. I have a lecture that I've researched for. It's the changing demographics of healthcare and the sandwich generation, and how it can be overwhelmingly positive for a child to provide that level of care to a parent because you connect on a totally different level and you really share an experience as opposed to this sort of subordinate relationship of child to parent. It can also be very physically, emotionally, and financially taxing. So yes, multi-generational families is amazing. It's a wonderful thing. We have to better support it financially, clinically, and socially as well. I think I got all the questions. There's one from Cheryl Lohman. Is it possible to schedule a time with me to show my prototype of KissBox? 100%. Laura will take care of you. I would look forward to seeing that, Cheryl. Okay. So we know that tech is going to help elevate us, and we can look at the trends. So in a 2-year study, individuals 50 plus, almost all of them, the vast majority were using a smartphone. And that's only continued to increase because it's almost impossible to get something that isn't. I have a 10-year-old daughter and an 8-year-old daughter, and they're just now starting to take the school bus home from school, and soon they're going to go. And my wife is saying, we really should have a phone, either at least one at home that they can access or one for each of them they can carry with them. And I started looking into it. Like, I'm not paying $1,000 for an iPhone for a 10-year-old. So I'm like, I'll get a flip phone or a candy bar phone. They don't make them. It's like almost impossible. You can get cheap smartphones, but it's what everybody has. Now, a tablet, they've become increasingly used by our senior population. What we've seen far greater adoption of, but still limited use, is wearables and the home assistant. So wearables, the overwhelming one is the Apple Watch, which every year they include new developments. I mean, the Apple Watch now, it essentially can check your pulse ox. It can track your pulse. It can track your steps. It can identify a fall. It's a great device that I will never wear. I got one as a gift, and I'm a watch guy. I like to wear wristwatches, and I put it on. I'm sitting in a meeting, and I kept getting pings, phone, text, email. So I went and I turned it all off. And then it was like reminding me to stand up and go for, I turned that off. Now all of a sudden it's just a wristwatch that serves no purpose. So I had this great idea. I would take the band off and I would make it my travel cell phone. Because the reality is I go out with friends for dinner. I go out with my wife. I need to send a text message, call an Uber, maybe make a quick phone call. I hook up to my earbud. So I took it off, I put it in my pocket, and it was fantastic. I used it for a couple of weeks. I didn't ever carry my cell phone anymore until I was walking at the beach. I tripped, fumbled it, and down into the sewer it went, and that was the last I saw of it. I will not buy a new one because they'll probably do the same thing. But wearables are becoming increasingly ubiquitous, and as are the home assistants. This is the Alexas, the LEQs. The use of this, because of their dynamism and their ability to access music and the weather and television shows and information, is really becoming far more encouraged for the senior population to stay connected. But then there's concerns about it. You know, Alexa's always listening. I will never let her in my house, ever. I am too much of a security freak to let a device like that in my house. But I have no objection to an iPhone, which I guarantee you I'll start seeing ads now for LEQ, for tablets, for wearables, because I've been saying it's listening to me. For some reason, I trust Apple more than I do Amazon or Microsoft. That might be misplaced, but regardless. So there are worries about it. And one of those is artificial intelligence. And I think this is particularly germane to the discussion today because I was invited to speak by Ann at the AITC. So AI is this hot thing. And everywhere you go, talking AI and this, AI and that, and how's it being used, and where can it be used, and what are the fears and the worries, and I hear all of it, and I get all of it. I share some of those worries, but I'm working with I have a couple of side projects. One is in the tech sphere. It's we call it tech-enabled care coordination. It's a proprietary tablet that goes in a client's home. It's called Viva Links. It goes in a user's home, so the senior. And it's tech-enabled, web-enabled. It's got the virtual assistant. It's got a calendar. It's got like FaceTime, games. It has medication management reminders. And then the child, the quote caregiver, has an app on their phone, and they can manage their parents' care through this app. It's more dynamic than that, but we don't have a whole lot of time. As this develops, so it's originally was a tablet with those items I touched on. It's now expanded to have remote monitoring. So the cameras will be installed in the house, and you can access it through the app and see all the cameras. We're now moving on to radar-based cameras. Not everybody wants a camera that's showing what's going on. You can see my whole office. You can see this window is open. You can see there's a fake cat behind me. You can see there's a lamp back there. Maybe I don't want you to see that. Maybe I don't want you to see me walking around with my shirt off. Maybe I don't want you to see me what I'm eating in the morning. Radar-based is more scattered technology. You just see an image. It's similar, but not quite as ham-fisted as the scanners of the airport where you stand like this. You walk out and you just see that yellow person. It's similar to that. It can show you where mom is. It can show you where dad is, but not what they're doing necessarily. So you can see if they're in a heap on the floor. Further, we're working with an AI group that is developing a product based on all this data they're capturing to do a facial scan. And based on the outcome of the scan, it can identify one of a handful of enumerated conditions, UTI, high blood pressure, something, all these issues that can lead to bigger problems, and warn the caregiver ahead of time. So AI can be very valuable. The flip side of it is the concern. All these large language models, all of these AI models are hoovering up information and data into a public cloud. So now it's all available. And what do we have access to? What information is there? Like, do I care necessarily that this AI cloud knows that Bryan Adler is on these medications or has this condition? Maybe, maybe not. How does that affect my life insurability? How does it affect my health insurance premiums? How does it affect my children? We have no idea. These are all things that we have to look at. And we also have to remember that AI, it's a tool in a toolkit. In the history of the world, there has never been something that has completely removed the need for something else that wasn't a variation thereof. What I mean by that, horses were replaced by trains, but we still drag things everywhere. Trains were replaced, well, trains have never been replaced, but planes now, it's still dragging information somewhere. We haven't invented whatever they do on Star Trek, where we can just materialize things. That's what I mean by that. What I mean by it's never been replaced, it's been improved upon. And AI is a tool, I believe, not necessarily a replacement for hands-on care, not necessarily a replacement for physicians, but it's an enhancement. There's a quote I heard, I'm sure you've all heard this already, that AI will never replace a professional. AI is AI will replace professionals that don't use AI. I think I said that poorly. The way I heard it was far more poetic. But regardless, you get my point. Physician practices, care communities, even lawyers that embrace the use of AI will enhance their practices. I look at my own practice. We're working on developing some software programs now. I got to figure out how to get people care. I got to figure out how to pay for it, which means I have to analyze pages, hundreds of pages of financial data. And we have staff, we have employees whose job is to take mounds of paperwork, scan it into our system, pull out key information, put it in a spreadsheet so I can analyze it. Well, there's software that we think can alleviate some of those tasks so we can take these people and repurpose them to other positions. There's AI can analyze this data much more quickly. So it's not about replacing anyone. It's not about doing my job. It's about doing my job better. So I get both sides of it. There's privacy concerns, there's ease of use, there's the cost. But when it comes down to it, I think it's like anything else. And you are all, my understanding is, professionals in this realm who my guess is you are far more educated or more experienced than I may be. So you understand a lot of this. And you probably have caught up to the fact that the train left the station, the horse is out of the barn, AI's here. Let's not fight it. Let's figure out how to use it and use it safely. So with that, I'll open it up to any questions that you might have. Let's see if there's any more in the chat box. Let's see. Anil wrote any comments on the role of generative AI? I have concerns about it. Now, my concerns are when it comes to the legal sphere, because I've seen problems with it in that arena. In particular, I've seen attorneys use it to write letters, briefs, plans. It's not giving good information. When it comes to generative AI, like I use ChatGPT to write, when I have to write scholarly articles, I'll type this is what I need to do, and I'll plug it in. And it'll give me all these starters, but then I go in and still spend a couple hours doing the research, massaging the language. I just use it to get me started. But I think it can encourage a lot of laziness that might already be kind of rampant in a person's personality. So I have concerns about it. I also have concerns about what we're uploading to cloud, same privacy issues. But overwhelmingly, I'm AI positive. I think it's a tool that's going to enhance care. I think it's going to provide better outcomes and reduce costs. Any other questions? You can feel free to put them in the chat. And while I'm waiting to see if there's any other questions, I want to invite all of you to use me as a resource. I'm an elder law attorney in the Philadelphia area and Southern Jersey. We have our care team, we have care advocates, health insurance advocates, OT, PT, lawyers. If there's ever a question or a concern or an issue you're facing in your research or your practice, so I can be helpful to you, you can feel free to reach out. Laura, who's with my team, will put my contact information in the chat. I am also always looking for opportunities to learn more. So if there's anyone out there that has a device or a product or a seminar or a conference that they think it kind of fills in, hits one of these topics we went on, please add me to your mailing list. Include me. I want to learn as much as possible. I'm by no means an expert in all of this. I have identified some issues. I've done some research of my own, but I want to meet as many people as possible. So acknowledging that, I thank you all for your time today. I see some more questions. Hang on, let me get back to those. So Laura wrote, thanks for your comments. Your experience and descriptions are for older adults with disposable income. How does the approach differ for people reliant on public funds? For example, many older adults have cell phones, but only use them for talking, not for apps like data collection. Laura, that's a great point. So, and I should have touched on this earlier. I'm glad you brought this up. Your comment, your question addresses the issue with tech. Early adoption is most expensive, so the wealth you're going to get at first. I'm going to use a very simple, ham-fisted example of a plasma screen TV. I remember in 2006, 7 or 8, I bought my first one. It was 42 inches. It was like $4,000, and I financed it through Circuit City over 2 years. Now, you look at a plasma screen TV that's 80 inches, and you're paying $800 for it. You can buy it with, changing your couch cushions in some regard. So to answer your question, the wealthy are going to have access to these things first, then it will start to trickle down. What we would like to push for when it comes to age tech is a Medicare coverage decision. And this is above my pay grade, but there are people that do this research and they look for Medicare coverage for various technologies. If you can get a national coverage decision, with this tech being necessary, it not only will drop the cost pretty dramatically and pretty quickly, it will ease access for everybody straight away. But strictly speaking, initially, it's going to be more difficult for those on public benefits to get them, because that's just sort of the way tech works. And it disappoints me to say that. Okay. Any other questions? Thank you all. This is really an enjoyable way for me to spend time. I hope some of you reach out with some information, experiences, opportunities for me so I can learn more. And I hope you reach out if I can be a resource for any of you. Laura put my contact information in the chat. And I'd like to thank you and AITC for including me. I look forward to our future work together.
Thank you so much, Bryan.